I'd just like to invite now our first speaker, Dr. Maggie Keeble, to come and join us at the rostrum. Maggie's a full-time GP working in Worcester, and her interest grew out of clinical practice, which I think is always a great way to start your interest, recognising that because you don't have a definitive diagnosis of end stage, you can get lost in the system. And she felt very much around equity, that people, regardless of where you are, have a right to a good death. And I suspect that's what's driven Maggie to develop this care pathway around the frail elderly in the community, which she will now share with us about. Thank you, Maggie.
Thank you. So, just to introduce myself, I am, is this working? I am a GP. I actually stood down from full-time practice about 18 months ago, because one of the reasons I'd always had an interest in palliative care and decided to go and do the Diploma of Palliative Medicine in Cardiff, and came away with as much respect as ever for the specialist palliative care services and everything that you do, but aware as a GP that there's a whole population of people who haven't got cancer, who haven't got a significant a single life-limiting condition, but are actually dying slowly, quietly, without the recognition and without the services of palliative care. So my mission really became to take the whole ethos of good practice from the palliative care services and actually try and in some way apply it to the frail elderly population. So we're going to have a whistle-stop tour today through the differences between specialist palliative care and general practice end-of-life care, frailty, and then some of the things that we are doing in South Worcestershire to try and address this problem. Okay, this paper was published in April of this year. It's the Equity of Provision of Palliative Care report, and it was commissioned, I believe, by Marie Curie, and the findings of the report was that cancer diagnosis is the primary determinant of access to specialist palliative care, which I don't think will come as a surprise to yourselves. 88% of palliative care services within hospital, again, were focused on patients with cancer, and 75% of new referrals to the hospice support and to outpatient services, again, were for a cancer diagnosis. But cancer actually accounts for only around 29% of deaths. So over 2/3 of deaths are not cancer-related. If you're over 90, in fact, only about 10% of deaths are related specifically to cancer. But only 16% of specialist palliative care is provided to people aged 85 or over. 39% of deaths occur in this age group. Kerry Thomas talks about the disease apartheid, that if you are ironically lucky enough to have cancer, you will get access to hospice care. So hospice and palliative care is particularly relevant for people with a single disease, actually for a relatively small population, cared for in a specialist centre, and it delivers a Rolls-Royce standard for a few. And I think that reflects the findings of the report that said that actually the UK is the best place, is the best country in the world in which to die. And I think that reflects all the work that palliative care specialist services are doing. But if you're an older person living with frailty, you tend to have multiple comorbidity. It's not just one condition. The population is large and it's getting bigger. Primary care is the place where most of this care happens. And within primary care, obviously, we've got the care home population. And what we end up with is often a full fiesta service for the majority. And we know that people without a specific diagnosis often miss out on any advanced care planning discussions and end up being admitted acutely and will often enough end up dying in hospital. And I know there's a great movement to improve palliative care services and end of life in hospital, but actually for a lot of these people, they would rather be in their own homes. So what are the challenges to providing end of life care for older people with frailty? the different disease trajectories, the size of the problem we've touched on, multiple comorbidity. Mental capacity is a big issue. A lot of these patients have got dementia, so advanced care planning can be really challenging. And a lot of patients are in care homes, and we are therefore dependent on care home staff, and I'll cover all those issues in a little bit more detail. So the disease trajectory, I haven't been here for most of the conference, but actually did follow some of Scott Murray's talk yesterday on the Dance Macabre. We're used to seeing this diagram, very familiar to us with the different disease trajectories. I absolutely loved his concepts of the different dances, the Scottish reel for that sudden rapid decline, the tango for that changing volte-face within particularly heart failure and COPD and organ failure. But it's the slow waltzers. It's the slow waltzers that I'm dealing with in primary care, and it's the slow waltzers who are missing out. So I think that's a really good image to keep in our minds when we're talking about this population. People are living longer and are dying older. And this slide is from the Office of National Statistics, and frighteningly, that's the date that I started at medical school, 1983. And in that time trajectory, the whole demographic has changed. People are living longer. Life expectancy at 85 is climbing and is not showing any signs of, it's flattening out a little bit at the top, but if you look at that over the timescales, that's an extraordinary achievement in many ways. Because people are living longer, they end up with more than one condition at the end of their life. And to translate this slide, if you get to 85, the chances are that you're going to have 4 or 5 conditions that you're living with long term. And this is really challenging when you're looking at managing patients with this multiple comorbidity. You can't attach, the rules don't work necessarily in this age group, and you've got to be able to bend the rules. Mental capacity issues. 1 in 6 people aged 80 or over have dementia. These figures all come from the Alzheimer's disease website. 2/3 of people with dementia are living in the community, and 1/3 live in a care home. And 80% of people living in care homes have some form of dementia or memory problem. I would challenge that a little bit. I think we're probably looking at a nursing home population rather than the residential care population, but that's just small beer. So, care homes. What are the challenges in care homes? We've already touched on the fact that the patients have multiple comorbidity and often have dementia. And then it's the staff in care homes. Care home staff, particularly residential staff and health assistants in nursing homes, they are the lowest paid in society. And we're expecting them to deal with some of the most complex and most vulnerable patients. In a nursing home, you do not actually have to have a state-registered nurse. You can actually have registered mental health nurses running a nursing home. And there are new people are struggling to get staff all the time, and you can have a nursing home where nobody has been really educated in catheter care or wound care, never mind end-of-life care. So it's really challenging to be managing these complex patients within a nursing home environment. Nursing homes vary. Of course, there are some nursing homes that are superb, and we don't want to throw everyone into the same bucket, but actually the standards of care in certain nursing homes do give cause for concern. Okay, so moving on to end-of-life care for this population. What does it look like? Well, end-of-life care for the elderly population should look exactly like it looks for patients with cancer. The first point, which is the most challenging thing in this population, is you've got to recognize that this person is dying. There's got to be a trigger for beginning to have the advanced care planning discussions that actually make a difference towards the end of life. So the first stage is recognizing that death is approaching. The next stage is discussion and planning. It's then good care at the end of life, bereavement care and follow-up care. So those are the building blocks, and they're the same building blocks for the frail elderly as there are for anybody who's got a single life-limiting condition. So what then is the trigger for this population? How do we realize that somebody is approaching the end of life? The GSF surprise question, apply that to a nursing home population. Would you be surprised if this person died in the next 6 to 12 months? Well, of course you wouldn't. But actually, how can we make that mean more? How can we make that more targeted, more realistic? And this is where we start to come on to the whole language of frailty. Frailty is not age-dependent. And this is a big thing to get across, that actually somebody of 60 can be frail, but somebody of 80 can be out there climbing mountains, chucking themselves out of aeroplanes, not frail. So we mustn't be ageist about this. It's about actually recognizing frailty. The problem is, and the problem up until now has been, well, we all have this sort of concept in our head of what frailty means, but actually it means different things to different people. And this was a qualitative sample of patients, elderly patients. It was done by Mori for Age UK. And they talked to a population of people that would fall within the umbrella of frailty. But these patients didn't recognize themselves as being frail. So there's lots of angst about what do we, patients don't see themselves as frail. Should we call them frail? Is frail elderly pejorative? We're beginning to talk about older people living with frailty. There's a lot of anxiety about using the word frailty. And I think that as healthcare professionals, we need to just sweep that one aside, because we can be anxious about calling something which is so obvious because we're using it as a descriptive term. And we've got to try and get away from the whole descriptive term and actually see it as a diagnosis. Once we've got a diagnosis, you can then, once you've recognized it, you can then do something about it. So we've got to stop using frailty as a descriptive term. We've got to use it as a diagnosis. We've got to see it as a long-term condition which you can define, and then you can manage it. And I tried to get across this analogy of obesity. Now, we all know when somebody's fat, they're fat. We're not very good at, particularly in the GP surgery, talk about the elephant in the room. Sometimes you try very hard not to, both of you, you and the patient, try not to talk about it because you know it's going to create conflict. But actually, we as clinicians, we define obesity all the time because it's anyone with a BMI of over 30. That's obesity. And we've got to start doing this, I think, for frailty. We've got to stop being quite so nervous about it. All sorts of definitions of frailty, and again, we've got a description of frailty as a long-term condition associated with, but not directly related to aging, causing a global deterioration of function, leading to reduced ability to withstand illness. Useful, but not diagnostic. Not when you've got a person in front of you. Have they got a long-term condition associated with, but not a useful definition if you're going to start measuring it. It's relevant because of what frailty does to people. And the whole point about frailty is that people with frailty decondition very quickly. And they dip from being independent to being dependent very quickly with a minor insult. And that's the whole point of frailty. They're very vulnerable, and they're very vulnerable to inappropriate or appropriate hospital admission. They're very vulnerable to sudden deteriorations, which often leads to a hospital admission. Frailty, the gold standard framework, they've tried to use markers for frailty there. People with multiple comorbidities, frankly, that's all the people over 85. We've just seen that. Deteriorating functional score. GPs know what a Barthel, an ECOG, or a Karnofsky scale is? No. Combinations of at least 3 of the following. Well, again, that's your elderly population. That's all of them. Again, how do you define frailty? The SPICT tool, a lot of you may have come across SPICT, again, very useful for recognizing and diagnosing certain end-of-life situations, but again, very sort of non-specific, could effectively be supplied to a lot of our patients, not terribly helpful in busy general practice. And then we had two very, very useful documents. And if anyone's interested in frailty, I'd really recommend this. One is the BGS. There are two documents, actually, Fit for Frailty 1 and Fit for Frailty 2, which talked about recognising and diagnosing frailty. And then the NHS England Toolkit for General Practice about actually creating frailty registers. Really useful. And I found this a very useful document, particularly the second one. They present a number of tools for actually diagnosing frailty and then scoring frailty. And what's been really useful in Worcestershire, in the South Worcestershire project that we're doing at the moment, we offer general practice 2 different scores to try and score their people with frailty. And the Rockwood Frailty Scale, which was developed by Ken Rockwood and his team in Canada, and was actually first published as long ago as 2005, we found this a really, really useful scoring tool. It's a measure of frailty based on clinical judgment, but it seems to be very consistent, the results that are coming out from this. And so basically, anyone with a particular frailties, with anyone that would fit into any of these categories, can then be coded into mild, moderate, or severe frailty. What's been developed in Bradford by Andy Clegg and John Young and co. is EFI, which is the Electronic Frailty Index. This is really potentially very exciting because what they have done is on System 1, which is, there are 2 main GP coding systems. One is System 1 and the other is EMIS. They have taken thousands of read codes and actually done a search based on this cohort of read codes, and it's created a score. You actually get scored on the number of these various codes that you have in your clinical record. And what they've begun to see is that the larger your frailty index, and they've divided them into mild, moderate, and severe frailty, actually very closely correlates with outcomes and the length of life that people have. Life expectancy. And this is being replicated and replicated. So this potentially gives us a way of recognizing people who may well be in their last year of life. And actually, they've brought it down to the alignment between actually at 365 days, what does that equate to in terms of EFI? And they're coming out to an EFI score of about 0.64. So it may be that we will begin to use this tool as a way of identifying people who are more likely to die within the next 12 months. We haven't got it for EMIS yet. We're hoping to get it at the beginning of next year so that we can begin to trial this as a tool in general practice in South Worcestershire. The other potential way of finding the severely frail is actually looking at the number of acute hospital admissions in a short period of time. This study was a Scottish study where they looked at everybody who was in hospital on a particular day on the 31st of March 2010, and then they followed them and saw who was alive 12 months later. That in itself is an enormous piece of work, extraordinary. And what they found was that within that cohort of patients, 28% had died within 12 months. If you were over 85, 45% were dead within 12 months. And if you were male and over 85, over half were dead within 12 months. And I think that's quite a salutary finding. And I think, again, we should begin to look at frailty admissions and more than one frailty admission in a 12-month period as being an indicator this person may well not have long to live. So, good end-of-life care, realization that death is approaching, potentially using frailty scores for diagnosis, planning ahead, carer support, last few hours and days of life care, and bereavement support. So just to mention briefly some of the things we've done in South Worcestershire to actually promote good end-of-life care for older people living with frailty. We've developed a contract for general practice to recognise and code frailty. We've used Rockwood to code mild, moderate and severe frailty. We've encouraged those with severe frailty. We've encouraged general practice to put these people on their palliative care registers. We've got a proactive care team who are going out and doing comprehensive assessments and advanced care planning with a lot of these people, using an integrated comprehensive assessment tool that we've developed. We're using an escalation plan that if people have made decisions about not actually wanting to go to hospital if they're less well, we've actually got a way of recording that and communicating that with out of hours. We've developed a communications folder that all this information gets put into, and we've got a team of care home nurse practitioners. The launch for the Frailty contract, that was in July, and John Young came and helped us do the launch with general practice, and we started in July, and in July we had about 35 people on frailty registers in South Worcestershire, a population of 250,000. Within 4 months, we've got over 2,500 people on frailty registers. So that, in such a short period of time, we've actually begun to see the language of frailty being used in general practice. Now, actually, coding frailty is one thing. Doing something about it is something else, and that's the development process that we're going on to now. But the very fact that GPs are recognising this and actually doing some advanced care planning and helping to support patients with frailty in the community, I think is really exciting. And as part of that contract, we're doing medicine optimisation reviews and multidisciplinary team working as well. This is just a snapshot of the comprehensive assessment paperwork that we're using. What we've got is we've actually got the proactive care teams who are working. They are community staff, but we've actually finally persuaded the community trust to enter, for these staff to be entering data directly onto the GP computer system. So all these sit as templates on the GP system, which means that all this information is flowing around the system, which is fantastic. And we've actually got GPs doing care planning. That's extraordinary. GPs don't do care planning, but we've actually got them recognising what that means, which is really exciting. These are the proactive care teams. There's a whole bevy of them out there in the community. We funded this through the what's known as the Avoiding Unplanned Admissions DAS, which was a directed enhanced service that came down to general practice 2 years ago. Different areas have done different things with the money that went along with that, and basically we have invested in teams of nurses who are doing proactive care in the community, working with a permanent caseload, no referrals into the service or discharge out of the service. They are case managing this population, getting to know them, which is, again, really exciting developments. This is our escalation plan. 3 categories within the escalation plan. If this person is less well, where would you want to be? Would you want to go to hospital? If you did go to hospital, would you want to be resuscitated? This gets around, or we're trying very hard to get around the DNA CPR form as being a block to admission, because I think a lot of people see that once that's done, it's almost as if people wash their hands of these patients, which is absolutely wrong. So we're trying to enable staff, relatives, families, ambulance crews, that just because somebody said they doesn't want to be resuscitated doesn't mean to say they can't go to hospital, because that may well be appropriate. So that's why we've got 2 categories within the acute hospital care. Home or community hospital, active treatment, that means look after me, treat me, give me antibiotics, but keep me at home if you possibly can, and then review me in 72 hours' time or whenever to decide which way we're going. And then home comfort treatment. If this person gets less well, under no circumstances should they be transferred to hospital. For example, if they are end of life, last few days, dying of a cancer diagnosis, or if they're end-stage dementia. Of course, if something acute happens, they fall out of bed, they break their hip, they need to go to hospital, but that is the exception. But otherwise, just look after me, keep me at home, and palliate my symptoms. So that's our ECAP. Now, one of the risks with these is the whole mental capacity issue. If somebody's got dementia, what evidence have you got that you've had that discussion with relatives? What decisions have you made? How did you decide on mental capacity? And have you made a best interest decision? We've built that into the form because of the risks of challenge. Green sleeves is just a plastic folder. We've stolen this from Coventry, our colleagues in Coventry and Warwick, who stole this from Australia, actually. With all these things about good practice, it's all about steal and share. So if anyone wants to steal or share any of these ideas, they're very welcome to talk to me and to contact me afterwards. So green sleeves, basically DNA CPR forms go into the red side of the folder. and any other advanced care planning discussions, documentation or ECAP goes into the green side. And then that follows the patient around the system. Hopefully. It's working in some places, not everywhere, but pretty much every care home resident in South Worcestershire now has got one of these in their records, and they are following them into hospital, and they are coming back out again. It's a bit hit and miss at the moment, but we'll keep plugging away at it. We've developed advanced statement document and advanced decision to refuse treatment. We did have an advanced care plan, but the terminology, as I'm sure you're all aware, has now changed. It's very much care planning as a process with an advanced statement as a written wishes. That is available if you Google it on, if you just Google for the advanced statement, Worcestershire advanced statement, you'll find it if you want to have a look. Feel free to steal and share. And then the care home provision. We've got care home nurses, care home nurse practitioners going into the 67 care homes in South Worcestershire, serving a population of about 2,000 residents. We've developed a local enhanced service for GPs, and they are being incentivised to try. What we've encouraged is actually to develop a system whereby one GP practice covers one care home. So you begin to develop some continuity and a regular visit in to sort of try and do some of that cold planning that gets missed if people are very reactive otherwise. And an expectation that there is advanced care planning done with all the residents and families. We're quite good at doing DNA CPRs. We're lagging behind with ECAP and some of that softer stuff. And just to finish, really, I mean, I'm talking obviously to a hospice audience, and I think a lot of people in the hospice movement are sort of scratching their heads and thinking, well, how can we contribute to this? It's vast. We haven't got the facilities, we haven't got the resources. And I think it's just about talking about how we can collaborate, how you can collaborate with primary care, how you can collaborate with your community colleagues, talking to the commissioners, talking to your GPs. One of the big things, as I'm sure you're aware, for commissioners is trying to reduce inappropriate admissions to hospital. I think there's a lot of work that can be done around that in terms of advanced care planning. And you know, if a hospice was to be able to provide a service offering advanced care planning in places where it's been recognised as a need, that may well be a way to actually extend your service into the community. There's a fantastic scheme up in Airedale called Goldline, which is provided by Hospice again. Having a Skype telephone consultation into nursing homes has been shown to significantly reduce admissions to hospital, and I'm going to, interested to find out more about that scheme. And then hospice at home provision. In Worcestershire, in St Richard's, there's a hospice at home provision. We'd love to have more of it. We're aware that a lot of CHC-funded fast-track funding for patients in their own homes. We are struggling to get care packages in place for these people because their care packages just aren't there. And actually, the quality of the care for people who are actively dying is not what it should be. And I think there's a big role for hospices to be supporting these patients at home. So those are a few thoughts. That's been a very rapid rattle through. And I'm sure, if you've got some questions at the end, very happy to answer them. Thank you.
Thank you very much, Kate. Thank you, Maggie. She makes it sound all so simple, doesn't she? Got grey hair on the head. Would anybody like to offer any comments or questions at this point?
So I think that's absolutely brilliant what you've said. My name is Karen Chumley. I'm the new clinical director at St Helena Hospice in Colchester. I've come from a 15-year career in general practice, and we're doing exactly this type of work, rolling out our hospice view into the community using the admission avoidance work that the GPs are doing. We're extending our end-of-life register to incorporate the uncertainty of the prognosis for older people. We're addressing our care homes. We've got about 2,600 people in care homes in our area. We, at the moment, only reach a fifth of those with our register for choice. So I'm very excited by what you're doing. I'd love to come and see you. I think there's lots to learn. And for a long time, it's really, I've been hammering on the door of the hospice saying, I want what you've got. out here in the community, and it's a fantastic opportunity to see that come to reality.
Thank you. Do get in touch, please. Thank you.
Any other comments? I just have a question really, or some thoughts really, Maggie, I'd like to hear from you about. You mentioned about the Rolls-Royce to the Ford Fiesta. Well, in my day and now, I think the Ford Fiesta is quite a good model. And we talk about the Marks Spencers or the John Lewis versus the Asda. A lot of us shop in Asda, and it's fit for purpose. And I suppose I'm thinking about those 8 components that you mentioned that were really critical success factors in bringing this about. Where would you say you are on that trajectory from Ford Fiesta to Rolls-Royce? And are you happy to be where you are? And if you are, where would you say you think you are that it feels the next steps?
I think, again, we've got, palliative care is being done better in general practice, and I think the palliative care registers and the co-op incentivisation has been helpful for that. But again, you've got pockets of good practice, and you've got areas where really it's not working well at all. My worry for general practice is as general practice gets busier and busier, and we see the pressures on general practice in terms of manpower, I'm just really concerned that, if anything, it's going to start to nosedive again because of resources. And then the issues in terms of funding for packages of care to enable people to stay at home, I think that is a big worry as well. So my concern is I think we're doing pretty well at the moment. It's how we sustain that with the inevitable resource limitations that we have that are coming.
Thank you. Can I just ask, generally, by show of hands, are you seeing an increasing referral with this very non-specific but needy frailty cohort of patients in your communities? And can I ask you, does it feel right at this stage? Do you feel that's an appropriate referral, or is it mission drift, or it feels like this is an area that we do need to engage in?
Can I just ask how many hospices have actually got policies around accepting patients with non-specific comorbidity onto their lists, as it were? That you will or you won't? Is that realistic going forward in terms of resources?
I'm Pepper Wilding from St Nicholas Hospice Care, and we're doing a lot of work with care home teaching and very much encouraging them, care home staff and care staff, to refer for anybody at end of life care. And I think some of it is professional anxiety that the professionals think the floodgates will open. But so far that's not the case, but we're looking at doing things differently by more telephone advice, by more education, and getting our healthcare assistants to go out into the care homes to work alongside the care staff, rather than being specialist referrals.
Thank you very much for sharing. Thank you. Siobhan.
Thank you for your wonderful presentation.
Thank
I
you.
really enjoyed it. I'm from Siobhan, I'm from St Luke's Hospice in Cheshire. And I've come to believe over the recent years we actually need to think about different groups and different parts of our population in really different ways. And the services we have at St Luke's, like most hospices, are very built around a cancer, illness, dying trajectory, a historic one, not maybe even a current one. And the population you were describing is kind of one of our biggest populations in Cheshire. We're one of the older populations. So we've been thinking about this in a very different way over the years. Yours is a new way and would really add in a lot, and we're going to take it back to our CCGs. But what we've been thinking about is, first of all, the groups of people with dementia, and we've set up a specialist dementia team that goes into care homes. That's quite new, co-funded with a partner hospice, East Cheshire Hospice, and the CCGs are going to pick that funding up in next year. But the other thing we're looking at is that development of a public health approach around compassionate communities, because most of these people, we can't pathologise this, actually live in communities.
Yeah.
The more we can support communities supporting each
Yes.
other, and we're thinking creative ways of having not hospice-based volunteer management, but community-centred
Yep.
expertise. Colleagues who are community members, paid for a few hours coordinating some of their friends and relatives to work with people who have frailty. And as you rightly say, you can be frail at 50
Yes.
these days.
I think, I mean, it's something that I'm really interested to see how we can engage communities, because I think we have to share this. We have to take it out to public health, because we have not got the resources to do it on our own. We haven't got the resources to do it for health and social care. But actually, we have willing relatives, we have willing carers who are only too glad to be involved, but we're often keeping them at arm's length at the moment. We have to do this as a community-wide I absolutely agree. And I'd be, again, if you could email me, I'd be really interested to just catch up with what you're doing.
The other and the last point is, and it's wider, I think as hospices we've got such a powerful voice and infrastructure. I see us as an infrastructure for doing good, and one of our new roles that we are developing is a community engagement girl who links all different kinds of support groups within a town together, because people don't talk to each other, even in small towns. And it's not that the hospice needs to do everything, but somehow creating that infrastructure for communities to do best. So there's multiple ways we can engage.
Brilliant. Thank you.
Thank you, Siobhan. I'd now like to ask Kate to come and share her story. Kate is, if I put my glasses on, Kate is from Salford, a colleague of Fiona from this morning's session. She's an author geriatrician and is going to share with us, using creative film, how she uses this medium to educate not just her colleagues, but her undergraduates, trainees, and hopefully the wider sector as well. Thank you, Kate.
Thank you. So, thanks very much for asking me to speak this afternoon. So, basically, I'm going to talk to you about a really big love of mine, which is film, but also about how you can use it as an educational tool, particularly with respect to geriatric medicine. So hopefully by the end of this talk, I may convince you to do the same. Did anybody see this amazing photograph that was on Twitter last week? This was taken by somebody who was coming into London during the sort of very foggy weather that we had last week. And it went viral on Twitter very quickly. And I think it's fair to say that visual media is very powerful. So this is a photograph that was taken in 1976 by a gentleman called Stanley Foreman, and it won the Pulitzer Prize for photography that year. So it's very unclear, really, isn't it, from this, what happened before and what's going to happen next. What we're seeing here is very much a snapshot. What had actually happened is that a fire escape had collapsed, and this is a young woman, and this is her 2-year-old goddaughter. And unfortunately, how the scene ends is the young woman was actually killed, but the goddaughter's life was saved because she landed on top of her. But what it sort of says is that with photographs we get snapshots, and I think that that's very true with the interactions with our patients, is that often we sort of see them during these episodes of their lives, particularly in hospital medicine. I'm sure for Maggie and people in the community, you may get a longer trajectory, but we see these snapshots and we don't know the bigger story. And I think that's where film can come in. So I'm speaking to you about cinema, sandwiched between the latest Bond film that's just been released, and also, obviously, we've got the new Star Wars film coming out in December, so it's a fitting time to talk about the power of cinema. So would anybody mind sharing with us the first film that they saw at the cinema? Mary Poppins. Any advance on Mary Poppins? Doctor Who? Anybody else?
The Empire Strikes Back.
Very good. So I think film really resonates, and this is a still from Space Odyssey 2001 by Stanley Kubrick, who says that if it can be written or thought, it can be filmed. And I think it's interesting to think about why film's so powerful. So Alexander, who's pioneered the use of cinema in medical education, talks about the synergy of word with image, geography with spoken word, and photography with music. So this leads us on to our first clip. So if we can just get the lights down. And let's go to the movies. Okay, so I think this short clip it's from the Pixar film Up, and I think it's a really poignant few minutes about a couple's life together, about, I think there's aspects of sort of frailty, living with loss, bereavement, and I think it's a really great sort of platform for getting trainees to reflect on the patients they've met, and also what it means when our patients lose that person they've been married to for sort of several decades. So nothing conveys information or evokes emotion quite as clearly as our visual sense, and no other art form pervades the consciousness of the individual to the same extent and with such power as cinema. And I think that's very true, and that clip, I think, illustrates that very well. So why is it so powerful? So Jung theorizes that it all goes back to these archetypal themes. And these archetypal themes are these primitive images that we inherit from our ancestors. And that a lot of these themes tell stories, and that often it's a variation of this story, the hero's journey. And we all know this story in a number of films, and it's told time and time again. And there's a theory that through this experience and seeing these images, that you can then transcend the sort of myth and to reality and use it as an educational platform. So we know the hero story in The Shawshank Redemption. In It's a Wonderful Life, George Bailey, that's the transformation story, which is a sort of a twist on the hero's journey. Darth Vader, he's one of the sort of dark form of the warrior theme, and there's a theory that the Doctor now represents the archetypal theme of the wise man. And these are all sort of powerful images and powerful stories. So currently in postgraduate medical education, I think it's fair to say that there's still a great focus on biomedical sciences, and the arts-based interventions often are used for the optional modules that students take. It's certainly not written into any curriculum, compared to sort of other programs internationally, such as the United States, the arts and the humanities form a much smaller part. And I think it's fair to say that geriatric medicine, much like palliative care as well, and any aspect of medical training, it demands humanistic skills, and I think that teaching those skills, I think we have to use the humanities to do that, because I don't think you can do that purely with biomedicine and biomedical models. So I think within geriatric medicine, we deal with complexity. There's lots of social challenges, things like carer burden, death and dying, and also we're always managing experiences of illness, and not just with our patients, but also with relatives as well. And I think the humanist sort of skills are very important. So the main benefits that film can have for educators, I think, are in cultivating some of those humanistic aspects, particularly around things like reflective practice, which is ubiquitous now across all levels of sort of training, communication skills, narrative analysis, where you start to look at the story. I mean, that's extremely important, is how you interpret the patient's story into what's important to them in terms of getting to a diagnosis. And also, I think film offers a really rich resource for illness portrayal, and that's across time, different cultures, and also different cultural settings. So I think it's also important to think about the learners and the fact that we're now dealing with the sort of millennial generation and their learning needs, and also their sort of preferred teaching methods, I think, have changed, and I think visual media is something that we should be embracing and using to our advantage. So there's no doubt that there's the act of collectively watching a film with your peers can foster reflection in a more powerful way than just watching the film on your own or reading an extract. There's something powerful about the actual collective experience. There's also some evidence that actually film can promote deeper disclosure of emotional experiences than just recounting something from your own clinical practice. And you can really challenge preconceptions by using film. So this leads me to our next clip. This is an absolutely brilliant animated film called Wrinkles, and it's based on a Spanish graphic novel. And I'm just going to show you the opening sequence, where we get to meet Emilio, and Emilio's got dementia, and it's the transitional point where he's just about to go into care. So we'll just show you this clip.
I'll be honest. With this kind of income, I'm afraid I cannot approve your mortgage. If you'd like, I can put you in touch with someone that
I
deals
can't take this
specifically
anymore.
with-
I know I said I'd try to be patient, but I'm sick of this every time we come here. For once, could you just do what we ask and stop playing these silly games? We don't have time for it today.
Sit back down, sir. In over 20 years as a bank manager, I've never had a...
Enough, Dad. We aren't in a bank. You haven't even worked in one in years. I'm not looking for a loan. I just want you to finish your damn soup.
My soup.
Look at the time. Late again. That's just great. Another ruined night. I give up. We're never gonna make it now. Tell Julian he can give the tickets to whoever he wants. I knew this would happen.
Calm down, Juan. They can leave the tickets for us at the box office.
What for? By the time he's finished eating, it'll be over.
It's just to show your
But
father
I can't
needs
constantly
us.
rearrange my life for him.
I've finished my soup. You can go.
So, media portrayal of geriatric themes. So, we all know illness represents major transitional points in our lives, and filmmakers often like to make films about these sort of emotive subjects. It can really help to promote experiential learning, where trainees can get exposure to sort of different cultural aspects of illness in different social settings. There's some really great sort of films sort of made internationally, where you can look at healthcare in other countries. And also it allows you to observe the story over time rather than getting that snapshot, which I alluded to earlier. And there really are a sort of plethora of films available. These are just some of the films that we use in our training program, where we got trainees to watch these films and then reflect back on the themes that they invoked, and also how they sort of reflected on what the film covered, how these geriatric themes were portrayed. So just to our next clip, so this is from the film Iris, which is about Iris Murdoch and her sort of with Alzheimer's disease. And again, this is useful for showing trainees about how dementia can affect language. There's also aspects about carer burden in there as well.
Oh, good morning.
Oh, no. I think it's the person who brings the post, John.
Yes, it is.
Yes. John? So sorry.
Thank
Very
you.
much indeed.
Thank you.
So sorry.
Go on. It's only the postman.
It's only the postman.
Don't repeat everything, Puss.
It's only the postman.
It's for you. It's your book.
What's that?
Your book.
It's only the postman.
It's your book. Isn't it perfectly splendid? Why don't you look at it?
It's only the postman.
Stop nudging up to me like a water buffalo. I have a lot to do. Lots to do, Iris. See what I've done now? It's not your fault. Not your fault. Sorry.
It's only the postman.
Yes, all right. It's only the postman.
Sorry, so sorry. It's lots to do. Which side do I go?
Okay, so you could see there she was very much mirroring his behaviour. You could see at the beginning where she was having problems with remembering the word for postman. So dementia's one of the very common geriatric themes that is depicted in films, and the narrative associated with Alzheimer's disease, the story, it's very much about loss of the story and the person's autobiography. In contrast to that, there's often magnification of the surrounding characters to contrast with the sort of person with dementia and their loss. And there's been a good systematic review which has looked at the portrayal of dementia in film. It very much often focuses on the terminal stage. It's often American productions, 75% were made in America. A majority depict female characters, and they're often characters that used to be prominent figures, obviously things like the Iron Lady and Iris as well. And often the patient who's got dementia lacks a voice, and they're sort of secondary to other characters around them. So I think it's important to say that the portrayal of illness in cinema is not always accurate. It can be stereotyped. But media perceptions of illness are important, I think, because society and a lot of our patients believe what they see in films or what they read in the papers, as we all know. So I think it's still useful to debate those portrayals, even though we may not agree with them or they may be inaccurate. Okay, so narrative analysis is all about understanding the human story, and there's elements to looking at a film in similar ways to how we might read something. So it's about looking at the language, seeing whether or not the narrator may be unreliable, and trying to organise those events to create some meaning. So this clip, I think it's from the TV series Scrubs. And I don't know how many times, I know I've said many times to patients that I'm going to keep them comfortable. And it's something that I've never really extrapolated, and the main character here, JD, sort of takes it to a next level and starts to think about what do we actually mean when we say we're going to make sure you're comfortable. And although there's some comedy to this clip, I think, again, this is a useful platform for discussing with trainees this concept of keeping someone comfortable.
Doesn't make sense.
Even though I had created a super medical crime fighting team, I felt lousy. See, I had just told Betty that her lungs had finally given out and she wasn't going to leave the hospital this time.
So, what are my choices?
Well, we could put you on a breathing machine, but it's unlikely you'd ever come off of it. Or I could just make sure you're as comfortable as possible. As comfortable as possible. I've said that 1,000,000 times and I still have no idea what it means.
There you go, Betty. That's every cotton ball in the hospital.
I am very, very comfortable.
Then you're ready to die. Look, Betty, is there anyone you'd like to talk this over with?
Okay, so in terms of how you apply this, there's various models in the literature. You can show an entire film and then have a seminar afterwards. You can show extracts and have discussions around those. You can get trainees to watch the films independently and then have a seminar. But I do think that if there is time, it's really powerful to actually get trainees sat down in a room together and to collectively watch the film. And obviously the model that you might choose depends on your objectives for the session, how much time you've got, and also what your sort of group numbers are. And I think you can also use it as assessment, and we used it really effectively in our master's programme for our registrars. We screened Amour, which is an absolutely brilliant film, on our last day of our master's training, and one of our psychiatrists came and did a seminar after that. And the trainees really gave really good feedback about it, and even trainees who I thought would probably perhaps not gel with the idea actually surprised me in terms of what they reflected on and their participation. So if you are thinking about trying to change your sort of educational methods, I think using a film can be a really good way of doing that. So I'm just going to end here with just a final clip from Amour and then take any questions at the end. Okay, there's some links to the films and any questions. Okay.
Thank you very much, Kate. I'd just like to ask Kate, we heard from the plenary this morning about that acronym ADA, how you move from action all the way through to, awareness all the way through to action. Can you tell us a bit about the impact that doing this exercise has on the clinician in the practice? 1 week later, 6 months later, what's the learning ripple effect?
With any sort of education interventions, it's trying to get to that sort of top level of the pyramid in terms of changing behaviour, which I think is what you're alluding to. I think it's been quite difficult to measure with arts-based interventions in medicine, but there's certainly evidence that you can change people's perceptions, whether or not you can translate that into actual impact on patient care at the end of it. But certainly from the experience we've had with our trainees, certainly in their feedback and doing some sort of qualitative analysis on that, it's definitely changed some of their views and perceptions about things, certainly in relation to when we showed them Amour.
Any final thoughts or questions? Right, can we just then say a very big thank you to our two great guests this evening, speakers. Thank you.